So very good evening to all, and I welcome you all in this very, very special and auspicious day. We called it Neurospinal Day celebration in this webinar series, NSSA webinar series of 5. And this Neurospinal Day, we celebrate in the memory of the special birthday of our respected and beloved NSSA founder, Professor Premanand Ramani sir. Wish you very happy birthday, sir. And we are very grateful that you are here today with us. Today's the special theme we have chosen, and particularly for all young budding spinal surgeon. And this is the essentials in spinal surgery, particularly in their beginning of the spinal surgery career. And for this, we are here and we are grateful to all our prominent faculties, national faculties we call in the spine surgery field group. I would like to invite on behalf of NSSA, we have our NSSA president, current president, Professor Manas Panigrahi. I welcome you, sir. He's from Hyderabad. I welcome you, Professor JKBC Parthiban, sir, from Coimbatore. And he is our current chief editor of the Journal of Spinal Surgery. And Journal of Spinal Surgery is the official journal of spinal journals for NSSA. Our NSSA secretary, Professor Batuk Diora. I welcome you, sir. And Batuk sir is from professor in the KEM Hospital, Mumbai now. I welcome all the speakers to participate today. I welcome Dr. Abhay Kumar, is the head of department, Kokilaben Hospital, Mumbai. Dr. Savitra Sastri, he is from Hyderabad, a senior consultant neurosurgeon. Welcome, Dr. Savitra. Dr. Rakshit Srinivas. Welcome, Dr. Rakshit. He is from the Ramaiah Hospital, Mumbai. He's a senior consultant neurosurgeon. Dr. Shraddha. Dr. Shraddha is a professor in the neurosurgery at Cooper Hospital in Mumbai. Welcome, Dr. Shraddha. Welcome, Dr. Apurva is our moderator of the session. And I welcome you all the delegates. Now, for our NSSA proceedings, I would like to invite Dr. Batuk Dior, our NSSA secretary, to start with.
Thank you, Jayesh. At the outset, I would like to thank Professor Ramani for guiding us to organize this webinar. I would like to thank Dr. Jayesh as well as Dr. Apurva and all the moderator as well as the chairpersons and the panelists. Before I start as a NSSA secretary, I would like to submit my birthday wishes to Sir. Sir, many happy returns of the day and my sincere prayers to Almighty God for your healthy and long life. I remember distinctly, like Professor Ramani has started teaching neurospinal surgery almost like 25 years by now. I remember clearly that in 2003 or 4, I was attending his lectures. He was organizing in Lilavati Hospital on every Thursday at around 9 o'clock, sharp 9 o'clock. Sir has to enter to the classroom and teaching the neurospinal surgery slide. With the core idea of teaching more and more neurosurgeons about the neurospinal surgery, NSSA was founded in 2010. And since almost like a 12 to 13 years, every year we are celebrating this Neurospinal Day on the 30th November. As a part of various activities by the NSSA that mainly includes the national conference as well as the interim NSSA meetings, various cadaveric workshop and the webinars. Now we are launching a new activity in the armamentarium of NSSA, that is a social media handle of NSSA. So now I will like to invite Dr. Shraddha Maheshwari and Dr. Achal to talk about this inaugural function of social media handle of NSSA. Dr. Shraddha, please.
Thank you, Dr. Batuk. Welcome as the Secretary of NSSA. And at the outset, it is Neurospinal Day today, and wish you a very happy birthday, sir. Sir turns 85 today, and I think more than half of his life has been involved in spreading neurospinal surgery, its education and propagation. Uh, as his student in neurospinal surgery, and what I have observed, what sets him apart from his peers and how he is still so active in the field is his motto, never cease to learn. Not only has he always kept up with the knowledge of the science that has been ever increasing, but his love for technology and technological advances have also been very evident and prominent right from the beginning days. He's always kept up with technology and the various, social media platforms that have been coming up. And the idea of having a robust social media presence or digital presence of NSSA also stems and is inspired by him. So thank you very much, sir, for giving us this opportunity. Also, I thank NSSA and special thanks to Dr. Aanchal Gupta, who is actively involved and is helping us out in various all these handles. And you will be soon receiving a lot more information and through this technological advance. Can we have the inaugural video, please?
Yes. Can we see this?
Yes.
Just play from the start, yeah.
We will start.
Yeah. Yeah.
So
Well done.
thank you.
Thank
Thank you
you.
so much for that warm welcome. And so, yes, these are the social media platforms that NSSA is going to be more visible now and will have a more robust presence, not just in India, but across the globe through these social media handles. Thank you. Thank you all very much.
Thank you so much, Dr. Shraddha and Dr. Achal.
Thank you.
Yeah. So, shall I invite Professor Ramani sir to say a few words and blessing, and then we can start our proceeding.
Yeah, it is a big honor for me to launch this. We are going further in the propagation of this particular knowledge on neurospinal surgery that we are launching today. This digital platform. I have best wishes for everyone. I wish them luck. I hope it gets very, very popular. Already we are on the world map. and this will help us to be more reach into the depths of the world, and that's a very positive sign. All those involved in the development of the neurospinal surgery and the digital platform, my best wishes. You work very hard. You will continue to work very hard, and that is what eventually what is required today is that patience, honesty, sincerity, and dedication. If you have these 4 qualities in you, you can take this NSSA much forward than what it is now already. With this few words, I thank everybody who has been very instrumental in bringing this up to this platform. Unfortunately, Dr. Vardhan Vallo is not here today. He's quite busy, but he has also been one of the person who has been very instrumental in propagating further. And then, of course, you all know Dr. Sumit Pawar. He has also been very active. We have this who are very active. And therefore, it's only with such active persons that we can go further and forward and forward. Thank you very much. Thank you.
Thank you so much. Thank you so much, sir. Dr. Apurva, I would like to request you to invite the chairperson and start the proceeding.
Yeah, thank you, sir. So with this, we start with the academic program for today. And I invite the chairpersons for today. Dr. Batuk, sir, he is here. Dr. Manas Panigrahi and Dr. JKPC Parthiban. And I request them to start with the academic session. We will keep all the questions at the end of the program. And I request the respected speakers to kindly stick to the time given. So, can we please start with the first lecture?
Yeah, so we start with Professor Ramani, and sir is going to talk about the position in spinal surgery.
Yeah, my very sincere apologies. I personally will not be able to give this lecture because of my commitment, because of the birthday today. Anyway, I'm very happy that I have been with you all this so few minutes here. Dr. Sumit Pawar will read the lecture for you on my behalf. Dr. Sumit Pawar, please.
Thank you so much, Dr. Ramani. Thank you for the opportunity. Hello, dear friends.
Welcome, Sumit.
Hello, sir. Hi.
Hello. Can the host please enable the screen sharing?
Support. Hello, support is there?
You can share. Sumit.
Yeah.
No, I'm not able to share. It is asking.
Sir, just you have to tell that tech person.
Arvind?
Or Jayesh bhai, temporarily you can make me the host, right-clicking the participants list.
Sure. I have not that option, Apurva. Arvind?
Yeah.
Please enable the screen sharing for Dr. Ramani.
No, they are not able to.
Not able to. It is showing host disabled participant screen sharing is the message that we are getting.
Make them host, Arvind.
Yeah, now it is there.
Okay. Yeah.
So can everyone see the screen?
Yeah,
Yes.
we can.
Yeah, clear.
Yeah, thank you so much. So this is one of the most, thank you, Professor Ramani, for this opportunity to present on one of the most important lectures in spine surgery. Before you go on to open spine surgery, spine fixation, could be CBJ, could be endoscopic, MIS, or whatever you want to do, unless it is a safe spine surgery, or unless we can ensure the safe outcome of the patient, it really does not have any much meaning in what we are doing. So I'm going to be reading about Professor Ramani's lecture and his views, what he has taught all of us, every single student that has been trained under him, all the people who have heard him, that The occurrence of spine problems resulted in emergence of spine surgery, the progress in technology, newer concepts, progressive popularity of surgical procedures. And today, the surgery in spine is at its peak. But how safe is it today? So we all know that Lucy, the ape, the first chimpanzee to walk like human beings, was that was about 3.2 million years ago, was discovered on 24th of November, 1974 in Ethiopia. And because of this erect posture is why we have so many spinal issues in humans, in biped animals, in especially humans. So just to give an example, 2 years back, this left fifth micro was done. Now the symptoms had recurred. She was a 25-year-old female. She's an ophthalmology resident. The right SLR was just 15 degrees, right ankle joint absent, and S1 root, she had sensory loss. So you can see on the MRI, there's a huge disc herniation along with inferior migration. I'm sorry, I can't see the screen. Just let me move the screen. Yeah. And somebody had done a 2-level PLIF for this patient. Again, look at the image. And again, look at this post-operative image. How many of you would agree that this was warranted? This was necessary. This was required in a 25-year-old young female. So today's lecture that Sir has made is based on these references, that is, published articles. So when we are thinking of safe spinal surgery, we have to start from the preoperative clinical assessment. That is done by us. The preoperative evaluation for surgery, the induction of anesthesia, the monitoring during anesthesia, difficulty in intubation if at all, the position of the patient, the level of surgery that you're going to do, how to control the venous oozing, the prevention of neural damage, the neuronavigation if required, the immediate post-op management, the relief of pain, and at the same time, evaluation of your post-op outcomes. So this article that was published by Altaf Patel was very, very essential. It had come in Times of India, that how important it is for us to have a preoperative checklist, just like the aeroplane pilots have. Any pilot, even if he has a 15,000 flight hours or 5,000 flight hours, they all have to go through a similar checklist. If the checklist is not complete, the ground personnel do not allow the plane to take off, how much ever famous the pilot might be, whichever airlines it is. And such a checklist is essential, I think more essential in our practice as well, because we are here dealing with the patient's life directly. Do everyone, all of us, have such a checklist that we're checking, and then the patient is subjected to the surgery? You all have to make your own checklist for patient safety. This is a representative case done by Sir a few years ago. It's a preoperative assessment by surgery. This was a high cardiovascular risk in a symptomatic neural compression. She's a 68-year-old female. On examination, preoperative clinical assessment, she was found to have a very high blood pressure of 240 by 110. Yes, she had spine problem, but she also had this high blood pressure. Uncontrolled diabetes with fasting blood glucose of 600. LV ejection fraction of 35%. NT-proBNP was 2500. And it took 3 weeks for patient to stabilize before even thinking and stabilizing the patient for admission for surgery. And once she was stable, once all the parameters were normalized, preoperative, clinical, before even the anesthesia or even the admission, the time taken for this double surgery, as you can see over here, was about 8 hours. But the surgery, the post-op course, was absolutely uneventful because everything else was taken care of even before admission of the patient. Another patient, a 57-year-old female with severe back pain, referred for PLIF surgery of L5S1 spondylolisthesis. You can see that, yeah, she has a grade 1 listhesis. Even on the X-ray, you can see it. But clinical examination showed that she had brisk ankle jerks and knee jerk with knee clonus. This set off to look at the, I think the slides are missing, but basically this patient also had a C1, C2 instability, which was asymptomatic. In this case, before the surgery, the entire time was spent on safe anesthesia and safe anesthesia techniques. The patient was put on a hard cervical collar, and during it was a fiber optic intubation was done, and then the patient was turned prone to protect the C1C2 joint before operating the lumbar spine. She was counseled and told that she was absolutely asymptomatic cervical spine wise. Cervical myelopathy was not active until now, but she may have symptoms and she may have to undergo surgery for that, was explained to her before touching her lumbar spine. So preoperative clinical and airway assessment involves the general evaluation of the health, evaluation by the anesthetist, treating the pre-morbid ailments, and clinical evaluation by a spinal surgeon. So it is, sir found it extremely disappointing and disturbing that surgeon hears from the patient after surgery that he feels good in the back, but he cannot see anything. So, the blindness in spinal procedure is a very, very distressing and scary experience. Reasons are multiple. The pressure on the eyeball in prone position, if not proper care is not taken between the eyes and the headrest, it can lead to pressure injury. It could result in corneal abrasion, could result in optic neuropathy due to pressure. What we need to do is the eyes should be taped shut with a micropore. After that, to avoid the pressure on the eyes, adequate padding, and we should avoid hypotension and low hemoglobin, which prevents or reduces the blood supply to the eyes. Retinal artery occlusion should be reduced. The chance should be reduced by reducing the pressure on the eyes. Now, in our institution, not in our department, but we have 23 spine surgeons. There are 7 cases of blindness post spine surgery. 5 of them completely improved within few hours or days of surgery, and 2 had permanent deficit over 18 years. Because Dr. Ramani instructs and personally supervises all the residents regarding how to take care of the eyes before starting the spine surgery. So you can see this many times. You see that this similar micropore is put on the eye, and then your patient is put on prone position. This is not recommended at all. It is very mandatory that after the micropore is applied, you should cover the face completely with adequate protection is given, and the anesthetist herself is giving all the protection. This kind of a gel pad is used that prevents the pressure on the forehead, on the eyes, and thereby preventing blindness post surgery. So we have many cases of difficult intubation also. It could be ankylosed spine, the displaced airway, a prefixed larynx. Multiple things might cause it. A video laryngoscopy in such a case is a boon. Without too much of neck movement or flexion extension also, we can have a fiber optic intubation. And this technology allows us to have very safe intubation at a very right time. Neuromonitoring is another way to have safe spine surgery, to protect our interest in the spine surgery and improve our outcomes. Any such intradural lesions, if you have support from the neuromonitoring team, it is very easy to remove the tumor. It is very safe, and we can, of course, you cannot rely on the neuromonitoring totally while removing the tumor, but it still gives us a very good indication while removing the tumor. BIS spectrum, the bispectral index, is something we use very, very commonly during the operative procedure because it is like a small EEG trace that is, among other functions, it tells us the depth of anesthesia. And this BIS is very, very important while neuromonitoring, so that patient can be in the perfect plane of anesthesia where he is not even aware of what is happening, but not too deep that the muscles become completely non-responsive for the electromonitoring. This is how the BIS monitoring looks like, and this is the ideal. And this is how the ideal quattro sensors look like when they're properly connected to the patient's forehead. Implants in spine surgery. The commonest implant in spine surgery is a pedicle screw. Here we can see a few cases of mal-positioned spinal pedicle screws. Today there is a technological boom which has resulted by the popularity of microscope, diagnostic imaging, intraoperative neural monitoring, minimal invasive spine instrumentation, endoscopy, laparoscopy, and more recently, the use of robots. The technological boom has created a fierce and competitive market. It has resulted in the industry being motivated and spine surgeons being biased. and there is a definitive case statistically proven that pedicle screw is overused. Implants have definitely a high rate of complication as compared to pure decompression. It also has a higher rate of morbidity. But there is an abnormal relation of spine surgeon with the industry, financial or non-financial relationship. The relationship with industry is important for the advancement of the research and academics for the healthy growth of the spine surgery. Like Professor Ramani, he has devised himself several spine implants. He has modified existing implants to make them more perfect. He had discussed the idea with the industry and see if they could improve the manufacturing of the implants. He has healthy relationship with many companies like Justco in India, Synthes, Paradigm Spine in Germany to develop the implants and make them safer and better in spine surgery. What does a spine surgeon desire? Professional advancement as well as recognition for personal achievement. But financial gains in mind creates conflict of interest, biased research, and influences the decision-making process. Now, just to take an example of the plated versus non-plated ACDF, cervical fusion. The Western world always prefers to use a plate after even a single level ACDF. Eastern surgeons are not so convinced about the plates. And the results, when you have fusion with plate, there is a 95% success rate. And when it is done without plate, it is 90%. Is the difference statistically significant is something that you have to ask yourself. And then you have to have transparency, choice, adoption, utilization of newer implants, training in its use, how to use it, familiarity with the clinical value and profitability to the patient, and transparency in dealing with the industry. The patient trusts in the surgeon and surgeons trust in the industry. The patient trusts the surgeon to determine if the operation is the best treatment of choice. And if the surgery is selected, is it the best method that is proven to be safe and effective for the patient? Many surgeons who themselves have spine surgery problems, they avoid surgery whenever possible. Why is it happening? There is an abnormal nexus, like spine surgeons and spine implants industry are intimately related. The trials are supported by industry grants. Many research presentations are favorable to the company product. The industry's primary goal is success in business, nothing else. Not success in patient, not necessary. And when do you really say that spine surgery is successful? We have evidence-based trials, like maybe it could be class 1, class 2, class 3, or class 4, a case series or a RCT. Each spinal surgeon should have a safety audit every 5 years on the patients he has operated upon. Philosophy is surround yourself with trustworthy people, because in the world today, there are lies, damn lies, and statistics, as quoted by Mark Twain. It's our job to make spinal surgery safe and comfortable for the patient. Thank you so much.
Thank you. Thank you very much, Sumit, for nicely showing the various nuances for the safe spinal surgeries. I think we have kept the question answer session at the last. So now we'll move on to the next presentation, and I would like to invite Dr. Parthiban, who is going to talk about the X-ray landmarks and fluoroscopy, practical application in spinal surgery.
Thank you very much, Dr. Batuk, and my dear friends from NSSA. I will share my screen and are you able to see this?
Yes, we can see.
Thank you very much. And the subject is basically we started, when we started neurosurgery, we had only tomogram in our hospital where we studied. Fluoroscopy was not there. I'm talking about the C-arm was not there. So I'm going to show you something interesting what I had experienced. Maybe some of you may have experienced this. And then we come to the new era of fluoroscopy. The X-rays were the only rooms, because you have to mobilize the patient to do something, to see something what is happening in the spine, whether it is lumbar spine, dorsal spine, or cervical spine. we have to shift, patient has to be shifted to the X-ray room, and then we will have X-rays. Then X-rays will be taken. It has to be kept in it is wet, and then you have to lift and see. Plain X-rays. If not plain X-rays, then we have to do some procedures called myelography. I will come to that a little bit later. But then X-rays are very fascinating, and we had something which are very standard and which are very common. We had something very common is you say the first rib is attached to T1 vertebrae. This is the common one. When you take an AP view and you see the first rib is always attached to T1. That is our understanding, our education. And from there you can count up. From here you can count up, and then we find C2. And then we have to get the anatomy, and the anatomy has to be converted into anatomical knowledge must be converted into radiological knowledge, and we view through the third eye. So the first rib is attached to T1 vertebra, which is very, very common. And then we have this another standard and common thing is the floating rib. The last rib is always attached to D12. Is always attached to D12, and then you count from there. So these are some specific landmarks we were taught at that point of time. And then one more thing, important thing is that the highest level of iliac crest crosses at the level of L4 and L5. So these are our routine teaching, and it is very difficult at that point of time to go beyond this. But however, we find quite a bit happening at that time. But the common things were not the same in clinical practice all the time. You will have many variables which can be experienced at that time itself. For example, the basic example is if a lumbar vertebra is attached to the sacrum, then it is totally different. Now you can't count from at the lower end where the L5 is or the sacrum is. Whoever reports it may report it in a various way, but then you have to find what exactly happening at this level, whether it is L5 or S1 sacrum. So these landmarks are very important, though they are common, but they are not the same in clinical practice because we see various different anatomical changes. For example, the congenital anomalies and the degenerative spine, the scoliosis, and also the same thing applies to the dorsal and also to the cervical region. So our teaching goes absolutely not 100% clear. So what we have to do is that we have to see this anatomy and correlate in the AP view, and then decide which level you have to go, because you need to do surgery. You do not have a latest gadgets. Now you look at this MRI, which is now in the present era, we are able to beautifully see L5 and S1. We realize this is sacrum, so that means this is sacrum, this is L5. Now you can see that, but in those days, this was not there. So L4, L5 here, you can see the disc prolapse, and we cannot see that disc prolapse because we never had an MRI at that point of time. So we had something else. And this is only one example that I'm giving for lumbar spine. Hence, what we used to do is mark your point. That is my point. That any point I am interested in, if I go back now, I can say, in case that instead of reading this as L5 and S1, if I wanted to reach this place, I will mark one level. This is my point. And from this my point, I have to reach to L4 and L5. Since MRI was not there, we used to do myelography. I'll show you a little bit later on what is myelography is. So hence you mark your own point and locate the level of pathology, level of interest, that is level of pathology from there. So it is very fascinating and very interesting those days because, we cannot do a mid-level surgery. And those days, we had most of the surgeries are open surgeries, large surgeries, and not very much minimally invasive or the minimal access surgeries as we want now. This is about lumbar spine. And we come to the cervical spine. Most often that we cannot find what is happening at the cervical spine at this region. So we can't see beyond C5 or C6 in the lateral view if somebody is going to have a very large shoulder. And so the technique was to make to have a swimmer's view. When one arm is kept above and slightly rotated forward, and the other arm is kept in forward, then you can see C7 and T1. So these were the points which we used to take it as landmarks in those days. So when we have a tuberculosis, which was very common in those days, so a strict lateral view may not give you the level of lesion. In case if a patient comes with a paraplegia and you feel that the patient has a lesion at T2, T1 or T2, then you have to do a swimmer's view. That apart from that, you have to do the AP view of the cervicothoracic junction. So this was the landmarks we used to use. And now you can see what is happening with the tomography C-arm now here. This is also another point which you can pull the shoulder down. You pull the shoulder down, then you can expose at least one vertebra down. Now this is very commonly seen. For example, that when you take an X-ray from the lateral view on a patient who's lying down, but if the same patient is made to stand up, the shoulder droops. Now you can make the patient to stand out and then make the patient droop to get the maximum number of cervical spines if you wanted to operate, whether to anterior or posterior approach. So this is a better way. Here I'm seeing one of these C-arm picture of present day. Just for example, imagine those days we never had a C-arm, how we would have done at this level a surgery at C7 and T1. So we have to calculate, we have to find the landmarks. One landmark which I like to mention at the cervical spine is that the C7 transverse process is the longest, so C7 spinous process is the longest spinous process in the cervical spine, but the one you always palpate is T1. So when we are interested to locate at the C7 and T1, you have to be much careful to do both AP and lateral view in the swimmer's position, and also cervical dorsal X-rays. So these, along with the changes, what you see in the X-ray finding, you can locate at C7 and T1. So the shoulder has to be pulled down with a sling around the wrist to expose it better. Now, always in the cervical spine, always check the upper end of the manubrium and the lower level of the cervical spine. What is the reason for that? Is because the manubrium it always comes in some patients, the manubrium is very high. That means the neck is short. In some patients, the manubrium is very low. So that means that you can reach the lower cervical spine very easily. So we always used to, those days, we always used to see the manubrium to which level it is correlating with the cervical spine, usually at C6 and C7. C7 you can down at T1. So these are the areas. So you can see so many X-rays. If you see the bulky X-rays, sometimes you can see the bulky neck where you find the manubrium is very high and it is very difficult to approach from anterior for the lower cervical spine. So always see the manubrium. Nowadays, you can see the manubrium very well in the CT scans because CT scans came later on. My topic is only on X-rays and C-arm. This is a very special thing I wanted to show you. And today, probably in recent days, you may not be seeing this. This is called the needle plaster strips. We have needles which are attached to these plasters, and these plasters are kept over just to the side of the spine. and then the APB is made. Now this plaster is not removed, this is fixed to the patient. You should not remove it. For example, in your myelogram, you find a defect over this region, then you know that your entry must be between these last two pins. So we have to correlate with the upper end of the crest and also to this pin. So these pins helped us very much when we were doing the landmark location for surgery. Now I'll show you a very interesting thing. You can also try this, and this was just for a demonstration purpose. I did this. You can see here there are 3 needles here, stamped here, and the X-ray is taken here. The L5S1 is here in this region. This is the L5 spinous process. This is the sacrum. Now, once you know that if you want to rent between go on L5 and S1, that is the upper needle, that is the upper needle here, then the middle needle. So this is the spinous process. So you can mark with a pen, that is the L5 spinous process, and put a needle slightly down. That means that you will be between L5 and S1. Now, I tell you one interesting aspect that here. Now, those days when you do the myelography, we find a defect here. This is how we do it. And believe me, what I learned when I was doing my fellowship program under Professor Ramani, we used to take the patient similarly to the X-ray room by side, and then we'll put a small needle like this and push it in and confirm it that it is in the L5S1 and put a plaster over this and bring it to the patient. This is done the day prior to surgery. The next day morning, this patient is straight away taken to the theater, and Professor Ramani used to make one small incision here and do the microlumbar discectomy. So that was the technique. Now, why do you need it now, sir? If you ask me, you cannot forget the history, and all the developments are coming only from the history. So we should know this. This technique, I really love it because this pin will stay there. Now the same technique now in the present day has come as localizing this small. They are putting a small coils, localizing coils. They are called in the recent development. This has come only from the past history. As I told you, you can see this pin at L5S1 here. You mark it there. And this is the surgery. This is the latest surgery I've done. This for demonstration. I've taken this picture. This is with the tubular retractor. We are done for this discectomy. So this is one type of needle plaster strip technique to localize, and these are the landmarks to localize whichever area you wanted to go. So the myelography, you must know about something about myelogram. That nowadays none of the neurosurgeons must be doing the myelogram nowadays, but in those days it is our daily procedure. We will be doing 2 to 3 myelography per day, and then we have to see where the defect is. You can see here now, this is the defect here. What we have to do is after getting the defect, we put the needle here or the strip here and pluck it here and then send it to the theater. That is the patient the next theater, or the day morning we do the myelogram, put a needle here and send it there and open this region and attack this disc prolapse. Similarly for cervical spine, that you know where exactly it is going. The myelography dyes. The myelography dyes were of 2 types. We had an oil type, and then the water soluble came. The oil type was very thick, and then when the water soluble came, then the definition was better. So you can see very well here. This is another one. You can see this localization. This is between D10 and D11. So whatever I said earlier, you can apply here with a myelography and then go to exactly that place. Now, if you are perfect, it's so interesting to do this spinal surgery 30 years ago or 40 years ago. But today it is much easier. But this is for all the youngsters to see because myelogram, I don't think that anyone is doing now except for the radiologist who does myelography for CT myelogram. So this point is that marking the surgical level with myelogram was much easier and was done at X-ray room itself. In situ interspinous needle, they are safe and permanent till surgery. Now we come to the present era to something which we use the C-arms. The C-arm is much easier. Now you watch here is a patient where I plan to do a surgery at L4, L5. Then you can see my finger at the crest, finger opposite to the crest, and palpate one of the spinous process. Put the needle down that, and then check it with your C-arm. With your C-arm, and you know where you are. The needle at L4 and L5 interspinous region. This is the disc. This is the MRI. So you're correlating with an MRI, and then put your tubular retractor. Put your tubular retractors. Here's the tubular retractor exactly at L4, L5, and do whatever you want. You do your discectomy through this tubular retractor. You dock it exactly at L4 and L5. So this is the way you can go ahead. And this is a very important one I like to show to all of you. This diagram is specially drawn for this meeting. This diagram is not there anywhere in the textbooks. This is my diagrams. This was done 2 days ago. This is called sequential needle and locate the area of interest. Many times we have a problem at the dorsal spine. You can see the floating rib, but still you can find it difficult. We are not doing the myelogram. Now we see the MRI. We know 8, D8 and D9, we want to locate it. You can locate it at your X-ray outside before the day prayer. Otherwise, you can do it on the table after intubation and position. For example, I used to put 3 needles, approximately one at L4, L4 or L5 and somewhere, and then another one at D12 or D11, and then one above. So what I do is the first C-arm takes about the first 2 needles. You can see that L4 and you can see up to D12, and then move the C-arm from there, bring the P2, that is the pin 2 here, and then the area of interest pin 3. So this way you can do a sequential needle technique. And this is very interesting, but it is very simple. You can try this, and it is, these landmarks are much, all this, whatever, because, each patient is different. Each X-ray will be different, each tomogram will be different. And so with this guided C-arms, and we are able to do open C-arm guided vertebroplasty like this, you can see. And here, since the topic of is landmarks and you know where to enter of the pedicle, you can also decide and do along with using your C-arm. You can see the pedicle, and then you can enter the pedicle with a sharp precision, and then inject the cement there. This is open C-arm guided cement, and this is the percutaneous C-arm guided. Same technique that was done for various reasons, and this patient is a different patient. You can see here is the entry with the C-arm guidance, and this is the entry into the pedicle of the C-arm guidance, and then you do the vertebroplasty. It becomes a very simple procedure using the C-arm. Now here the C-arm is down now. Here the C-arm is down in this way. Now this is a big thing is that the X-ray is a fixed one. Now the C-arms can be mobile, but nowadays I see much sophisticated X-ray machines which are always they are kept on the corridors, and they are very small and they're easy, and we can do it very much. Now another case, it's timing.
May I request you to conclude, because we are running out of time. So I think
I'm finishing.
Yeah.
Percutaneous pedicle screw. This is another case with the same techniques as I told you, and the same thing can be done with the C-arms. That's all I think I have for my presentation. My conclusion is that the generations which come from the X-rays and the knowledge we gain from the C-arm is it's much faster, and we can always use all these principles in your practice. Thank you very much.
Thank you so much, Dr. Parthiban, for a very exhaustive presentation. I will just want to make a small comment regarding that. You have shown an X-ray image about a location of L1 vertebral body, because in many times there are 11 ribs. So it's very difficult to count the vertebral body on the base of the ribs. So what we usually do, we do one good X-ray chest PA view that includes the first rib to almost 12 or 11th rib. So then we are clear because there are many 11 ribs in many patients like. So thank you very much again. Manas, around? Dr. Manas?
I'm there.
Yeah, may I request you to invite our next speaker?
Yeah, I think the next talk is on essential MRI sequences and its clinical application. And Dr. Rakshit Srinivas from the head of spine division at MS Rama Medical College, Bangalore. He will be telling us on the essential sequence of MRI after listening to the basics of X-ray from Dr. Parthiban. Dr. Rakshit, can you please start? We cannot hear you. Dr. Rakshit, you have to unmute. Dr. Rakshit, we cannot hear you.
Rohit, you'll have to unshare and then unmute yourself and then share again.
Yeah, he's unmute now. Now I think, yeah, now we can hear.
Good evening, respected Professor Ramani sir, respected chairpersons, moderator, convener, and all the NSSA team. At the outset, I would like to thank Dr. Jayesh and the NSSA team for giving me this opportunity. The topic allotted for me today is an investigative modality which has revolutionized the diagnosis of spinal disorders, essential MRI sequences and its clinical applications. So I would be going with the introduction, the general concepts of MRIs, recommended sequences for anatomical localization, and common case scenarios that we come across. So as you all are well aware that imaging protocols are less standardized for spine and spinal cord as compared to brain. The main reason being the interfaces that exist, the bone and CSF, spinal cord and CSF, proximity of the lungs when it comes to thoracic spine, and the mobile nature and the size of the spinal cord. The MRI, as in the brain, is taken in 3 sequences. That is the sagittal sequence, coronal sequence, and the axial sequence. The aim is to learn the different MRI techniques by the various anatomical structures like white matter, gray matter, CSF, vessels, and leptomeninges, and disc and bone structures. What is the most adequate technical protocols that we need to follow for particular spinal disorders? The specific sequences that we would like to ask our technicians to provide. Now, going to the basics of MRI, the sequences that are indispensable for spine is T1 weighted, T2 weighted, advanced sequences like STIR, which is short tau inversion recovery, diffusion, DWI and DTI sequences, vascular or angiodynamic sequences, CIS, constructive interference in steady state, perfusion, spectroscopy, and functional. So as you all are aware, T1 is used for the normal anatomy. Fat appears hyper and water appears hypo. In T2 sequences, water or edema appears hyper and fat appears hypo. It is used for the evaluation of pathologies. Steered sequence is a special sequence that we commonly use in spine. In this sequence, there is suppression of fat. So it gives better definition of bone and disc structures. The FLAIR sequence is a highly T2 weighted sequence. It helps in the detection of white matter abnormalities. Gadolinium can be used along with T1 weighted sequences for characterization of lesions and also for MR angiography. DW and ADC are used for characterization of acute ischemia or abscesses or tumors with high cellularity. The gradient echo will help localize blood or calcification. Now going to the T1 weighted sequence, like I told you, T1 weighted sequence is used for the normal anatomy. As you can see on this is a sagittal image of a dorsolumbar spine. This is the vertebral body. The disc appears as hypointense. The CSF is hypointense, and the spinal cord is isointense. What is very glaring is the fat. Epidural fat is well seen in a T1 weighted. Hence, this sequence is commonly used for lipomeningomyelocele and its classification. And also T1 weighted is very useful for tumors where most spinal tumors are hypointense on T1. The T2 weighted, which basically shows the pathology and water content. So this is a sagittal T2 weighted MRI, which will show you a well hydrated disc. The CSF is hyperintense and the spinal cord is isointense. So the pathologies that we can diagnose with the T2 weighted is disc herniation, hypertrophied ligamentum flavum, canal and foraminal stenosis, hypertrophied facets, vertebral body edema, flow voids, tumors, and infections. Like I mentioned, the steer sequence, basically it nullifies the signal of fat, and hence the abnormalities appear more hyperintense and can be easily identified. This is an example of a case of multiple sclerosis where on a T2 weighted, you can barely see the lesion, but on a stir sequence, you can see the intradural lesion in a case of multiple sclerosis. The DWI or the diffusion sequences, they measure directional diffusion of water in tissues. This can be performed in advanced MRIs, which are 1.5 and 3 Tesla and the now 7 Tesla. The basic indication is for ischemia. The DTI can be used for surgical planning in case of spinal cord tumors, which will define your approach. It can also be used for cases with cervical myelopathy and also to differentiate between spondylodiscitis and modic changes in degenerative vertebral body. The picture on the right demonstrates an aortic aneurysm, dissecting aortic aneurysm, which results in an ischemia of the dorsal spinal cord. And the image lower shows the cervical myelopathy, which can be followed up. MR angio is the dynamic vascular MRIs, which improves the visualization of small blood vessels. There is an arterial phase, a venous phase, and a 3D gradient echo MRI. So this helps visualization of normal vessels, the case of artery of Adamkiewicz, which is extremely important to localize, especially in a case of an aortic aneurysm before the treatment modality, and abnormal vessels like AVMs and dural AV fistula. This is an example of an AVM with the feeding artery and a draining vein. So the MR angio has almost replaced the requirement of an invasive angiogram. The CIS sequence is a T2 space and a heavily weighted T2 images. The flow artifacts are less visible as compared to conventional T2 weighted MRI. It is useful to visualize thin and tiny structures like thin-walled cyst, which could be post-traumatic or congenital, dural herniation of the spinal cord, dural breach and CSF leaks, arachnoid webs, pseudomeningocele, normal or dilated vessels. The image on the right shows a sagittal and axial images, which are where you can see a herniated spinal cord at the dorsal level. So phase contrast MRI, which I'm sure all of you all are very well aware of, or cine flow, is very useful in Chiari malformations with syrinx. It would probably indicate the benefit of doing a foramen magnum decompression. Post decompression, you can see good restoration of the flow posteriorly. Perfusion MRIs are advanced sequences which are used, which will help visualize, help grade the primary tumors and also identify extradural metastasis. This is an example of an intramedullary mixed intensity tumor with both a solid and a cystic component. You can see on a T2 weighted, there is a hypointense solid and a hyperintense cystic component, which the solid part is enhancing on contrast, and on perfusion as well, you can see perfusion of the lesion which shows more vascularity and a higher grade. Now going to recommended sequences based on anatomical location. When we need to diagnose anatomically structures in the white matter, as you all are aware, white matter is there in the periphery of the spinal cord containing the sensory and the motor neurons. The sequences that are used are T2, STIR sequence, GRE, T2, with both sagittal and axial cuts. The lesions that are commonly identified in the white matter are multiple sclerosis, neuromyelitis optica, infection, ischemia, vascular malformations, nidus of an AVM, edema in the dural fistula, and vitamin deficiencies. DTI can also be used, as I told you, for planning of surgical treatment. So this is an example of a patient with vitamin B12 deficiency. You can see a hyperintense lesion on T2 weighted, which is present in the posterior columns. Now going to the gray matter, which is a head shape or a butterfly shape. Axial gradient echo MRI is of use in identifying pathologies of the gray matter. Advanced stages of cervical spondylotic myelopathy showing myelomalacia can be picked up on T2 and STIR images. It is important to note that while applying a contrast in T1 weighted, even in a case of advanced degenerative disease, there can be enhancement and should not be confused with tumor. This is a GRE image showing a case of vaccine-associated paralysis, where you can see hyperintensity in the gray matter. Now going to vessels, the MR angiogram is used to identify both, like I told you, the normal artery of Adamkiewicz, which is of great importance. And as you all are aware, it is somewhere, the radicular branch arises somewhere between TA to L1. The abnormal vessels that can be picked up are AVMs or dural arterial venous malformations. For the CSF, we use a T2 space and a CIS sequence, which is a heavily T2 weighted, which helps differentiate flow artifacts and true structures in the CSF. It is useful to diagnose webs, synechiae, cystic tumors, dural herniation, and dural CSF fistulas. Phase contrast MRI, like I said, can be used for Chiari malformations. The leptomeninges, a GRE sequence can be used to identify siderosis due to bleeding from a vascular lesion. A fat SAT T1 weighted with contrast for tumor dissemination or for epidural abscesses. So this is an image showing an epidural abscess with peripheral enhancement. The tip or trick that one needs to know is based on the enhancement pattern. If there is a smooth enhancement, it is more suggestive of an infection, whereas an irregular or a teardrop shaped enhancement is more suggestive of secondaries. Now going to the nervous system, the brachial plexus and the lumbosacral plexus can be well visualized by an isotropic sequence with a large field of view, showing the entire roots, trunks, and divisions using a 3D STIR phase space MRI. The MRI preferably should be done not during the acute phase, because that could confuse with edema of the nerves. For bone and disc, as we know, T1, T2, and STIR images are used. The discs are usually hypo on T1 and hyper on T2. This is also seen in case of infection and tumor. Leptomeningeal enhancement commonly seen in infections and tumor arising from dura. So the DWI, like I told you, shows a clause sign which differentiates between modic changes and spondylodiscitis. Now going to a common case or run-of-the-mill case that we come across, lumbar disc herniations. The sequences that we prefer is a T1 or a T2 weighted with STIR images, both sagittal and axial. It is important for you to go through all the cuts of your sagittal images all the way laterally to be able to see the foramen. And on your axial image, you need to identify the spinous process. Sorry.
Rakshit, we have 12 minutes over. So.
Yes, sorry. So cervical, again, T2 weighted MRI is used. Now, spinal tumors can be, we use a T1 weighted contrast and a T2 weighted. Now, the take-home message is essential sequences for MRI spine is T1 weighted with or without contrast, T2 weighted MRIs, steer MRIs, diffusion, and MR angio. It is very important that MRI is only an adjunct. It is extremely important to take a detailed clinical history, examination, and localization, and talk to your radiologist or technician what kind of MRI you require. Thank you. This is the reference for if you want to note down and go through the MRI sequences. Thank you so much for the opportunity.
Yeah, thank you, Rakshit, for explaining elaborately and lucidly the different sequences. Some of the names, actual full form, we don't give importance to know what is STIR or what is CIS. You clarified that, and I'm sure the audience also would have enjoyed learning the basics of MRI in spine. We'll have the discussions later. We'll look for questions in the chat. We'll go to the next topic by Dr. Savitar. Savitar, can you please share yours? And Dr. Savitar is a senior consultant neurosurgeon at KIMS Hospital, Hyderabad, and he'll be speaking on screws and constructs.
Am I audible?
Yes.
Good evening, everybody. I'd like to thank Jayesh and the NSSA webinar team for this opportunity, and I'd also like to wish Dr. Ramani a very happy birthday. I'm here to speak about screws and screw constructs that are commonly used in spine, and I know we opened with saying screws are overused, but there are indications for fusion, and that's when we use these implants to achieve spinal fusion. Now, this is a really, really old construct, and this is what we used to use prior to the invention of pedicle screws. And this is likely a loop fixation or a Harrington rod, which is attached to the spine by multiple sublaminar wires in a patient with scoliosis. But when we think about the difference between a screw and a nail, it starts with the most important fact that the screw is simply a device that converts rotational motion into linear motion. So when you turn the screw, it moves forward into the substance that we are turning the screw into. A nail, on the other hand, transmits force via a small point to drive the device in the direction of the force applied. Now, when we look at the standard pedicle screw that we use today, there are a few characteristics that we need to remember. One is the screw itself has a core, and then a spiral that goes around this core, and that's what gives the screw its property. Screws then also have a head, which is often referred to as a tulip because of its shape. It has a body. And when we look at the spiral around the core in a little bit of detail, there are a few numbers which are important. One is the pitch, which is basically the distance between the two spirals or the distance that a screw will move forward when rotated by 360 degrees. The next important thing is thread depth, which is how deep or how much the threads come out beyond the core. And finally, the type of the tip of the screw. Is it a sharp tip or a blunt tip or a fluted tip? Screws are further then divided into their cortical versus cancellous screws, where cortical screws tend to have a more dense pitch to hang on to thicker and denser cortical bone. Cancellous screws have a wider pitch because cancellous bone tends to be a little less dense, and a more aggressive pitch could lead to screw pull-out. Single lead threads versus dual lead threads is basically the distinction between how far the screw will move in one rotation. Single lead threads, it moves the distance of one pitch, but with dual lead threads, the screw actually moves double that distance. We have top loading versus side loading screws, and we'll get to that when we speak about screw and rod constructs. We also have monoaxial versus polyaxial screws, which is determined by the amount the head rotates or whether the head is fixed to the shaft of the screw. Finally, we have fenestrated or cannulated screws, which cannulated screws have a hole running across the length of the screw, which allows for passage of a K-wire through the screw. And fenestrated screws have multiple perforations towards the tip of the screw, which allow for dispensing bone cement. And finally, we have self-tapping screws, where I mentioned earlier, the tip of the screws tend to have a fluted edge, so they're able to tap their way into the bone. Other rarer used screws are the modular screws that you get nowadays, where the tulip and the head are completely separate from each other, and it's possible to put the head in to do and prior to doing the decompression work, do the decompression work, put a cage in case you're doing a P-lift or a T-lift, and then snap the tulips on top of the screw heads and finish the construct. The next screw, the second screw that we see here is a screw that is used specifically in subcraniovertebral junction. And this has a smooth surface followed by the threads. And this is used in C1 screws to make sure that the threads don't irritate the C2 ganglia. The third screw that we see here is the minimally invasive screws, where the screws are attached to either a tower that is welded to the screw that can be broken off, or they have towers which can be snapped onto the screw and then unscrewed. The fourth screw is a screw that is used in the cervical spine to anchor the plate. And the important thing about this screw is there are further grooves on the head of the screw, and this is what locks the screw onto the anterior cervical plate. This is also, like I mentioned earlier, a fluted screw, which means this is self-tapping. Final screw here is the C2 odontoid screw, which is a lag screw. And it's called so because the distal part of the screw is what goes into the odontoid fragment. And because the proximal part is smooth, as the screw is tightened, the distal fragment is pulled onto the proximal fragment, causing compression across the fracture, which is required for fracture healing. Now, which screw to use and when? Now, this depends on what kind of surgery we're doing and what kind of patients we're doing. The profile of the screw in thinner patients when we're doing long segment fusion, and this becomes important when we're dealing with younger patients with scoliosis, such as patients who are 16, 17, who are not obese, who have very little both paraspinal musculature and subcutaneous fat. A top-loading screw tends to have a much larger profile. And we have the lowest profile top-loading screw that's available, still has a bigger profile than side-loading screws. So typically, side-loading screws are used in deformity correction, and these tend to be monoaxial. And again, the monoaxial screws, if we're going to be dealing with translational rotational forces during correction, monoaxial screws, at least the earlier generation of monoaxial screws, are far superior to polyaxial. However, there are some newer polyaxial screws which are able to counter the initial disadvantage. Now, the need for reduction in cases of extensive spondylolisthesis will lead us to use a reduction screw, which has a really, really long tulip where the rod can be gently forced into the tulip, and that can cause reduction of the anterior migrated vertebral body. And finally, when we're dealing with really osteopenic or porotic bones, we can consider using both dual-threaded screws, which have been shown to be effective in holding on to osteoporotic bone, and fenestrated screws, which allow for cement augmentation. Now, the most important thing that we need to recognize when we're dealing with pedicle screws is something called pull-out strength, which is the force required to pull the screw out of the pedicle. And that is dependent on multiple factors, and this is not strictly in order of importance, because I would say technique is still the most important factor in determining pull-out strength. The type of thread, there is some evidence that cortical type screws may be the best screws to hold on to osteoporotic bone, followed by dual threaded screws. The bone density, of course, in extremely osteoporotic patients, no matter what kind of screw you use, it may not hold. It's probably wise to increase their bone density prior to surgery if it's an elective surgery. But in these cases, we would prefer screws with a distal fenestrated hole through which we can inject cement. The technique, conventional traditional pedicle screws require a convergent trajectory. So what happens is there is a large triangular piece of bone that prevents the screws from pulling out, as opposed to a more parallel trajectory. And cortical type screws, which start from the medial aspect of the pedicle and go outwards and upwards and anchor to the upper end plate of the bone, have also been shown to have a much higher pull-out strength, especially in osteoporotic bone. And finally, the construct type will also determine pull-out strength, and we'll again outline that in just a little bit. So this is typically the convergent trajectory that we would use in traditional pedicle screws. As you can see, there is this triangle of bone anterior to the spinal canal bounded by both the screws, and that is one of the reasons that increase the pull-out strength of such a construct. The images on the right show the typical cortical trajectory, and the reason this, even though it's a much shorter screw, the reason this has a higher pull-out strength is because it goes through the extremely hard cortical bone of the pedicle and anchors onto the cortical bone of the end plate. Now, the basis of all of our constructs in thoracic, lumbar, and cervical spine is the screw and the rod construct. So typically, the rods fit into the tulips of the screw and are anchored down by set screws or locking screws. Now, every manufacturer has a different kind of set screw or locking screw, a different mechanism of tightening it in. And honestly, what is most annoying is they all have different screwdrivers that push these screws in. Some of them are star-shaped, some of them are hexagonal, and they're usually not compatible with each other. This can often be a problem. But the set screws are also very importantly torque limited, which means that most manufacturers will allow you to tighten the set screws to a predetermined torque. And torque is basically the tightening force. So what that does is it prevents the screw from over-tightening, which can lead to early metal fatigue and implant failure. Now, the various constructs that we use are kind of shown in this slide. So for a single level lumbar fusion, for example, we would use 4 screws, which is something like this, on 2 on each side. So you have 2 screws and a rod, and you have the locking cap. So there would be 2 screws on each side. With every additional level, we end up adding an extra screw. Now, when we start dealing with longer constructs, which require more levels, there is a requirement for additional stability, and that comes from this cross connector. And we will outline this again down the line. This again shows the way the screws would go in. Now, typically, this is what we're looking at. This is the X-ray of a simple 2-level construct with a cage, and this would be a 3-level construct with 3 screws on. Sorry, a 2-level construct with 3 screws on either side. So when we start using additional hardware, it starts becoming like a toy shop, and there is no end to the kind of hardware that we have. So this pretty much, outside of maybe one additional bit of hardware, shows what we would normally use in a long lumbar construct. So these are dominoes which are used to connect a fresh rod to a pre-existing construct in case you're doing a revision surgery. These are cross connectors which run from the left to the right, which help in achieving rotational stability of the construct, especially if we're doing more than 2 levels. These are offset screws, which are traditionally used in pelvic instrumentation when we put in iliac screws. So the iliac screw heads tend to be more lateral than the S1 screw heads. So these require an offset connector to be able to attach them. And finally, iliac or pelvic screws tend to be longer and thicker screws to be able to go from the iliac bone all the way to just above the acetabulum. The only other thing that's missing here that I haven't yet mentioned is you get telescopic rods. So if we're doing a fixation from the cervical to the thoracic spine, the cervical rods tend to be thinner because the screws themselves are thinner. Whereas as we move to the thoracolumbar spine, the rods tend to be a little thicker. So we have rods that start off thin and then expand into thicker rods when we're doing fixations from, say, the cervical spine down to the lumbar spine. Now, as we move to more complex constructs, this is what you might end up seeing. So in cases of deformity, you're looking at a long segment with a cross connector, you have hooks at one end, and you have offset screws and an iliac screws as well. Similar to here, these are, again, this is probably in a case of failure where two separate systems have been added to stabilize the spine. And what's also interesting is this patient has a bilateral hip replacement, which is very likely if both the SI joints are also fused. This is a occipito-cervical construct, which I just added for completion. And this is an occipital plate which screws on with short screws into the occiput. And we have screws going to C1, C2, and the C3. Now, the other constructs used in the spine these are tandem constructs that hook onto the spinous process.
With 12 minutes is over. So.
Yeah, just finishing up. These are hooks which are used either sublaminar or subpedicular. The newest kid on the block is a spinal cord tether, which is a flexible cord made of polyethylene, which is used in scoliosis, especially in younger patients. Finally, the materials that we use, the screws typically used to be stainless steel, but now are titanium, and usually medical grade titanium. Sometimes, and nowadays also we're looking at tantalum to be added on. The rods, again, we don't use stainless steel anymore because of MR compatibility and biocompatibility. The commonest rods are titanium. However, in long segment deformity, cobalt chromium rods are being used due to their better biomechanics. The cages that we use for interbody traditionally are titanium or PEEK, which is a polymer, which is osteoconductive, coated PEEK, which is PEEK with titanium on either side, or allograft bone. And finally, where technology is headed is carbon fiber screws in malignancy, where they don't interfere with radiation planning. PEEK screws and PEEK rods are also available, which are again compatible with radiology. Polyethylene tethers is what I mentioned earlier. Nitinol is a heat or force deformable material, which is traditionally used in stents, which is now being explored in spine. And finally, tantalum screws, which has a little better biocompatibility than titanium, but extremely expensive. I'd also like to end by inviting everybody to NSSA Spine 2024, which will be held from 19th to 22nd September in Hyderabad. And the theme will be optimizing spine surgery with newer technology. And I invite everybody to register and make the conference a grand success. Thank you.
Thank you, Savitha, for a beautiful exposition of the different materials and the different construct. As Dr. Sumit said, it's not only the decision making of to fuse or not, but also using the right construct, understanding the biomechanics, and using the different types of construct to prevent complication and failure. That is the key to success in spinal fixation. I'll request Professor Parthiban to take over and invite the next speaker.
He has already come, Dr. Abhay Kumar. Come on. Abhay Kumar should.
Yeah. Thank you, sir.
Tell us something about your OAM navigation better than what I did. Come on.
So nothing is better than the individual anatomical skill and techniques. These are all adjuvants, but I think we need to get used to this as well, because in future, I think things will move on in this direction. So good evening, everyone. Thanks to the NSSA team for inviting me. I've been asked to speak about OAM and navigation. Since this is a beginner's guide session, let me talk about the basics about the OAM and navigation first, and then try to convince whether is this a future, or is it something else come beyond this already. Yeah, so this is what I will be talking about. This is the S8 navigation system and the OAM, which I use routinely. Basically, OAM is as we know, intraoperative CT imaging system with the mobility of a C-arm. Basically, this is a cone-based cone beam CT scanner, unlike what normal CT scan, which is a 64-panel scanner. This has a capability to have a 360. It's a basically 360-degree scanner. But The soft tissue windows are not good as we see in a normal CT scanner. So if you are using it for a brain, we cannot use it only for to see for the ventricles and the hematoma, but not for the detailed bony detailed brain scan. For bone, definitely it's good. It will give a 3D reconstruction. It's basically a flat panel detector with the X-ray source which rotates within the gantry. So it has a 3D capability. It has a telescopic gantry section. It gives a faster imaging with a very significant less radiation. And the 3D imaging which we acquire can be automatically transferred to the navigation system. We can use it multiple times and navigate the imaging, the fresh imaging every time. So one of the things we need is we always need a radiolucent table for this, either a Mackay system or a Jackson table. This table is very useful, particularly when you're doing a CV junction or a cervicothoracic junction surgeries. One of the other things we need to know is the radiation dose. The effective dose is much less compared to the normal CT scan as well, and even the fluoroscopic imaging as well. For example, an abdominal region, if you do an O-arm, the effective dose is as low as 3.21. So the radiation also is much, and this is the biggest advantage of using an O-arm in the operation table. So let me talk in basic about the navigation. As we are all neurosurgeons, we know we've been using navigation for ages and we know the basics, but I just will quickly go through this. Basically, as we all know, navigation is like a GPS system. Basically, the camera here emits the infrared signals, which are reflected from the spheres, or which we call as glyons, from either the reference frame or from the moving instrumentation. And the signals which we get from these spheres are triangulated by the computer and which is reflected on the monitor to us. Basically, there are three components. One is the pre-operating imaging data, which we first load into the computer. Then we register it, and using the localizing tool, which has the glyons on it. And with that, there is a mathematical framework in the software itself, which will give us the relationship between the patient's anatomy and the pre-operative imaging. So navigation flow is as like in a brain. It's a pre-operative CTR and some imaging, register the image to the patient, and then navigate. As we all know, there are two types of navigation. One is optical navigation and second one is axiom navigation. Optical navigation based on the infrared signals. The axiom navigation works on an electromagnetic field. Basically, this creates an electromagnetic field around the patient. There are miniature sensors on the surgical instrumentation, which creates localization information within that magnetic field itself. For the spine, mainly we use optical navigation, but now newer technologies have come which are getting even axiom navigation even in spine as well. So I'm sure in future we'll move away from this tracker reference arc putting, and we might move on to the axiom navigation even for the spine as well. So essential components for the navigation and O-arm is the navigation itself, the software itself, plus a monitor, plus all these reference arcs are required, and the surgical instrumentation, which a tracker attached to it, or we can attach these trackers to the different instrumentation. And we need a recent imaging data, either a CT or in a case of brain, in an MRI, and we can load them and navigate it. In the patient, the reference arcs are very important. For the open, we have a different type of reference for minimally invasive. Also, we have these two are the spinous process, which are attached to the spinous process. There are reference arcs which are attached to the iliac crest as well. So these are the different trackers. We are all aware of the Sure track system we are using for the brain. And this is where the reference frame is attached. But if you want to put the reference frame on the spinous process, this is how it is attached, and the flow. These are the glands which will be reflecting the infrared from the rays from the camera. If you want to apply on the iliac crest, this is how it will look, and this is how you can navigate after you are registered and when you're using the instrumentations. So the flow is this one. The basically gantry can open, it can go inside on the patient, and then the gantry will be closed, and that's how we do the imaging. We'll do an intraoperative CT scan. One thing we need to know before you do the imaging, there are trackers on the O-arm itself, on the machine itself, which has to be reflected on the monitor itself. If you by chance miss this, whatever imaging you will go waste, and then you will not be able to navigate it. So before you take an imaging, you need to see to these trackers, the reference arc tracker spheres and the O-arm tracker spheres should be visible on the monitor. The flow is basically you select the surgeon, the procedure setup as like this, and then verify the different instrumentation. You might have acquired the image either before, or you can and then verify the instrument, or either way you can do it, and then you can navigate. Once you've taken the O-arm image, you can transfer it to the navigation machine and navigate it. So as a neurosurgical applications, we use it for both the brain and spine. There are multiple applications in the brain and spine as well. But for the spine, to just talk of, basically it is used for a pedicle screw fixation, either in the lumbar, thoracic, and scoliosis correction. And it's also used in C1-C2 fusion. So the most important in spine usage is this one. So where we accurately place the pedicle screws without violating any of the borders, particularly the medial and lateral border. So this is the basic use of the O-arm and navigation in spine. If I can show you once this patient, the lumbar pedicle screw fixation, I'm using the pack needle, and this is you're using the tap. And this video is showing the putting the, we are navigating, putting the pedicle screws itself. Just to move on, this is the flow, just a video, I'll fast forward it for the lack of time. So basically you put the reference arc is put in, you put the imaging, and then once you acquired, using the pack needle, you can put the pack needle inside, then the guide wires are put in. Once the guide wire is done, then using a tap the pedicle. And once it is adequately tapped, put the pedicle through. And entirely, there is no fluoroscopy done throughout the procedure, except once you want to cut in the end. Sometimes I do it, but only 2 images. There's no requirement of any place at all. So throughout, you can do it. So I'll just. So next is you can also use in C1-C2 fusion, where here we have placed the already the cages are put. You can do either you can do the O-arm imaging before putting the cages itself, or after putting the cages as well. You can do the O-arm, and then you can navigate. Here you can put the reference arc onto the Doro-Mayfield clamp as well, rather than putting on the spinous process. But I try to put it in the spinous process. There are people who are using it by putting into the Doro clamp itself. And this is a case where we've done a C1-C2 fusion, where the C1 lateral mass, we're tapping here. This is the tap, and that's the screws going in. So that's a C1 lateral mass. Even the C2 as well can be done. Again, this is using a tap, and that's a screw. Just to give us an idea that it's very easy to use this, and is much more user-friendly and surgeon-friendly as well. Again, thoracic, I'll cut short this video, even thoracic. What are the key benefits? Main benefit is the less radiation to the patients and the clinical staff. Because it's only hardly we use a fluoroscopy, maybe in the beginning once and maybe at the end, but this is the biggest advantage of using the O-arm and the navigation. Again, the second advantage is the precise and accurate live visual guidance for the patient for the screw and implant placement. Particularly useful in redo surgeries and complex deformity. Also useful in cervicodorsal and upper thoracic spine, where you know that fluoroscopic images are not very, very good. And if we keep using this more and more, it definitely reduces the surgery time. So I'll just show you my one small study we had done after using 2 years of O-arm, about 68 patients, a small study just to find out what about the screw violation. Total screws were 396, and I used this Gertzbein classification to classify the violation of this screw. In this study, we found that O-arm and navigation, we are out of the 396 screws, only 6 we had perforations. When comparing with the C-arm, of about 132 screws, there are 9.8% screw violation. So definitely it helps us to place the screws accurately and prevent any neuro deficits and avoiding any further surgery, resurgery as well. So what are the disadvantages of fluoroscopy? It has a drawback of it lacks high accuracy, inaccessible, particularly in areas of craniothoracic junction and CV junction, particularly inadequate imaging in patient with obesity, severe deformity, and osteoporosis. Main disadvantage is the high radiation risk, particularly if you do a minimally invasive spine surgery. So if you use 2D navigation, compared to 3D navigation, you don't get an axial images, through you cannot get a 3D images. So that's the advantage of 3D navigation. Now, 3D navigation not only used in pedicle fixation, now we have started using it precise localization as well. Dr. Pathiban was mentioning to us whether using the multiple techniques using a pins, but now we can avoid this using a worm, and the thing we can exactly localize, particularly when you're doing any tumor cases, or even you're doing a fixation for even a small 1 or 2 level fixation as well, to exactly localize. We don't need to do X-rays before. We can just use this worm, and plus the tracker itself will tell you exactly where you can mark the incision as well. So is there a literature supporting it? There are a lot of literatures available. I'll quickly rush through this. This is one of the paper which clearly shows the navigated screws. The violation is around 3.7% compared to a non-navigated screws, which is around 9.7%. The conventional fluoroscopy in this study, so in the conventional fluoroscopy, the screw insertion accuracy was around 68%, but when you come to 3D fluoroscopic navigation, it is around 95.5%. So there are a lot of literature available, and there are more literature available about the radiation exposure itself. There's significant decrease in the radiation when you use worm. I won't go to the detail of this. There are a lot of papers available which clearly shows the decreased radiation exposure when you're using a worm, and particularly when you're using a minimally invasive spine surgery. So the less revision rates, less operative time, and the less hospital stay when using worm-guided pedicle screw fixation. So what are the technical pitfalls about this? Even now, in obese patients, you still will not get a good quality images. There's a surgical learning curve when you're using the worm with the navigation. You have to select the surgical table. We have to spend more on this surgical table as well, particularly Jackson or a McKay, which is a radiolucent one. Reference arc selection has to be done depending upon the patient plus the type of procedure you are doing. We need to do draping as well of the worm. Complex OR setup is required. Registration process is required. A trained technician is required, particularly when you're doing a lot of cases. Again, while doing during the procedure as well, we'll have to maintain the navigation accuracy, see to that the tracker doesn't come out. Too much pushing also shouldn't be done because the navigation can be inaccurate. And initial phases, yes, it is an increased operative time. The familiarity of the surgeon with the use of navigation system, it's not a substitute for a surgeon's knowledge, skill, or competence, but there is also a learning curve for it. It's for the safe and accurate placement of the pedicle screw. My conclusion is pedicle screw placement using a navigation worm is much safer than a conventional fluoroscopic technique. Radiation exposure is much less with this technique. Surgeon confidence is particularly doing redo surgeries and complex deformity surgeries will be more when you use an worm and the navigation. Thank you, sir.
Thank you, Dr. Rabai. Very nice, very good talk, which is very essential for the day, and it is absolutely fantastic. But this navigation and OARM, it really has pitched up higher on our spine perfection of spine surgery, certainly in many areas. Thank you very much for your nice talk, and we will discuss it at the end of the this one. Now, our president, Dr. Manas Panihiri, will be discussing on the training and fellowship programs for young neurospinal surgeons.
Welcome, Dr. Manas. Yeah. So the concept of this discussion is, at the earlier of their learning curve in the spinal surgery, there are a lot of debates and a lot of controversies, what to do, what not to do, something there is in mind. So you have vast experience. We considered you as a highly successful neurosurgeon, and we are glad to have you here. So a few questions I would like to ask so that, some points would be clear for all our young friends. So first, would like to ask about just a brief about your post-MCH journey till date, in brief, so we can learn more from that.
See, when I did residency at NIMANS 89 to 94, during the training, not much of spine experience exposure we had, except for discectomy. We did not have an exposure of any spine fixation. But after joining as a faculty, as assistant professor at Nizam's Hospital, there pedicle screw fixation was done by Dr. V.S. Prasad. But then I did not have a formal training in spine fixation. So my first training with the pedicle screw was with Professor Ramani, where I used to go to Bombay to attend his anatomy, this cadaveric workshops to learn spine fixation, and then come back and then help Dr. Prasad, who used to do spine fixation at Nizam's, and slowly I learned how to do it on my own. Many of the times when I finished residency, people used to go to abroad to get trained on spine and all those. The important thing is not just looking at the horizon beyond the country. One has to see what is done in and around you, and then learn from everybody who is with you and around you, and that helps in learning. And every time I went for any conference abroad, I made a point to spend 1 or 2 weeks in a center in that city to learn new things. Because it is not possible to have 1 year fellowship of spine, 1 year fellowship of skull base, 1 year of vascular. So one has to do one specialty fellowship and present on that. But then one has to know basics of all the things, so that you do not deny basic treatment to a patient.
Right. So you mentioned about observership and fellowship. So what is your concept about that? What is the basic difference, and how to choose and why?
Choose is it depends on the place where you're working, whether that if something specialty is missing, then you take interest in that. And you should have a passion for learning something. So if in our center that time skull base was missing in Nizam's Hospital, so I chose initially to do skull base. But then spine fixation is something which every day a patient comes to. In the OPD, skull-based cases will be 5%, but 90% will be spine. So as a neurosurgeon, one has to learn doing spine treatment, basic treatment. Now the advanced treatment for doing advanced treatment, one has to do fellowship. So one has to be very clear, one will do a basic treatment of a specialty or an advanced treatment. If you want to do basic treatment, one can do away with observership, but one has to do advanced treatment on a specific specialty, then one has to do a fellowship in that specialty.
So after pass out, what do you think means after 5 years or after 10 years, the person should start searching their fellowships or training center, or he should immediately after pass out, immediately should go for some centers and then should start private practice or join their clinical practice? What is the ideal period?
See, the ideal, many times we like to do something, but then when you really do it, we don't do it it doesn't happen properly in our hands. So, if you practice what you have learned in your 5-6 years of residency for 2-3 years, one can know that what he is good at and what is his weakness. So he can always promote what you are good at, and and then you decide to do fellowship. So I feel that if after 2-3 years of practicing in a department where seniors are there, then one can do a self-evaluation that what is some that one can do it well and go for fellowship in that, so that in 1 year one can learn. But if one jumps immediately after MCH to do a fellowship, then one has to do for 2-3 years because that learning process will take longer time. So so there are two ways uh, that one can work for 2 years, then do a short-term fellowship of 1 year. But if one is planning to do immediately fellowship, then one has to at least do 2 or 3 years of fellowship in a specialty to master the technique. One also has to realize that it's not always possible to get a fellowship immediately after your MCH because finding a fellowship has a latent period. So in 2-3 years, do regular work and then one should not think that depend that I did not get a fellowship immediately. So after 2-3 years, you can still learn by doing a 1 year fellowship instead of 2 or 3 years of fellowship.
Right. So you mean for early period 3-4 years at least we should do a general practice and find out what is the area of interest and what is our cup of tea, and
Yes.
then choose something, and then we should do a clinical practice. You want to advise for our delegates. You want to advise some centers, national centers and international centers, spine for their beginning. They can choose their spine practice for fellowship center.
For fellowship.
Yeah.
Before I answer this, I like to ask all the speakers who are very good in spine, in which places they do their fellowship. I'll start with Dr. Parthivan. Where did you do? Because if you know where they did fellowship, I think I'll have the list of which are the good places.
Okay, you see, I tell you very, very openly, I tell you, because it was in 1991, I finished, and then I was in Cochin and went Medical Trust Hospital, where when I went there, I found so many spine patients just lying over there. Then, there were no teacher, no one had told me how to do pedicle screw fixation. But I've learned the theories, and I've listened 1 or 2 times to Professor Ramani. Then I went through Roy Camille's this diagrammatic books, which are old books, and then I did myself pedicle screw, and I first used the rodal drill. Please understand, it's very, very, very rare. It's a rodal drill in orthopedic surgery. And I fixed it. Then only I realized that, those days we have only the Steffi plates, right? In the Steffi plates, first you have to put the screw, then put the rod, put the that plate, and then put the check nut. I was not aware of that. So what I did was first I put the pedicle screw guidance, and then I put the plate on top of that and put the screw. I was just wondering what is the other one is holding on top. I was not aware of that, but then I cut it that. So that was the beginning. But then later on, I realized that about after 8 months, I was doing all kind of spine surgeries, including I tried PLIF after listening to Professor Ramani in a meeting. And then finally, I went to Professor Ramani for a 1-month program in 1991. And he called me. And very honestly speaking, that the first few days, unfortunately, for the first few days, there were no cases. So he was a bit nervous. Then, he was not able to show me any case. Now, I was expected to see anterior cervical, microdiscectomy, all kind of things. A lot of imagination for a young neurosurgeon in 1991. Then I asked him, sir, since you don't have a patient at present now to demonstrate, can I show my slides, which I have done? He agreed upon. And then on the first day of the second day of the fellowship program, third day of the fellowship program, I presented my work. You believe me that he was surprised. He said, where did you learn this? I said, sir, I don't know. I tried my best. I heard you. I listened this. I saw Roy Camille's arts, and then I did this. So by the time I had done anterior cervical, lateral mass, thoracic fixation, pedicle screws, cliff also. Then he said, "You are the guy who need a polishing." I stayed with him for 1 month period. 1 month period, you believe me, the way he modified me, it was amazing. So what I realized was that the young neurosurgeon must see one master. And particularly after some experience, as you rightly put it forward. In my case, it was about 8 months period time where I worked without anybody's help, a freedom of doing myself. I was bit reasonably safe enough. But after seeing Professor Ramani doing the dissection of the cervical spine, the putting the pedicle screw techniques, the microlumbar discectomy divisions, I totally changed. When I came back, my surgeries were faster, precise, and better. So I only did, I never had any international exposure, nothing. Only Professor Ramani for 1 month. That's my experience.
Rakshit, can you tell your experience?
Yes, sir. Sir, I was in Satya Sai Super Speciality Hospital, Whitefield, where I did a large number of open cases initially. And then my interest into minimal spine was ingrained after Dr. Sudhir Dubey came for one particular case. And then from there, I went to UK, Cambridge University, Edinburgh Hospital, where I did under Mr. Ricky Trivedi, a fellowship in minimal invasive spine. Since then, I'm practicing minimal invasive spine at Ramaya, sir. Almost 95% we do minimal invasive spine and open about 5% for the sake of the postgraduates.
Thank you, Rakshit. And Savita, can you tell your journey?
This is going to be a little embarrassing, but I've honestly had no formal training in spine. Like you said, I trained in MHANS. We didn't have as much spine exposure when compared to brain. But when I moved out and I joined, I was Rakshit's neighbor, I joined a medical college called Vaidehi, and I found that there were about 70 to 80% of the work was spine. And I knew some basics from NIMHANS, and then I just built on learning things by myself. And I think in 2015, I did an observership with Dr. Benzel at Cleveland Clinic and with Dr. Girish Hiramat for minimally invasive spine in Riverside Clinic, Columbus. And since then, I've had great mentors, Dr. Umesh, who was my senior in NIMHANS, and who's taught me a lot of the minimally invasive work that I do. But like you said, so I think beyond a point, once you're senior enough, I think a fellowship is not required. But I think if you reach a level of competence where you can watch a surgery be done and you're confident enough of the anatomy and you know the anatomy and you're confident enough that you can be safe and know your limits, I think an observership is sufficient to start learning to do new things. And nowadays, of course, we have a great cadaver lab at MS Ramaya, and I've attended multiple courses there, and that has given me the knowledge to be able to do minimally invasive spine surgery without having had a formal, a certificate that says I've had a fellowship in MIS.
Yeah, Dr. Abhay.
Manas, I was fortunate enough, as you all know, I had done my whole neurosurgical training in UK. I was at Neurological Institute of Neurosciences at Glasgow. So after finishing my 6-year neurosurgical training, I got interested in spine, and I continued as a spine fellowship under Ian Johnston and Jennifer Brown there, and I worked for 18 months there. That's where I was a consultant for about 6 months after that, and then I moved to India. So I was really fortunate enough to be there with them for nearly 7.5 years, and that's when I gained interest in spine, and I learned my minimal invasive spine surgery through them. So to be honest, I have not got any training here, that is training there, but here I learned a lot by moving to different institutions, attending cadaveric workshops as well, plus looking at all the surgeons' videos, plus all the attending these webinars as well.
Thank you, Abhay. Jayesh, can you tell your experience?
Yeah, I have just done two short observership. One is at HE Spine Center, Japan, and one at Korea, South Korea, with Dr. Kang Taek Lim for endoscopic spine surgery. Particularly, what I believed about fellowship in observation, I agree with the Savitra that fellowship is not necessary. It's not mandatory in Indian standard of education, because we have a lot of, we are lucky enough that we have a lot of patient data to take. What I believe that we should first, give ourselves 3-4 years or the time in open surgery. Then let's generate the question first. For example, for first 3-4 years, I have done lots of open spine surgery. Then I have a question: how people are doing TILIF, what they removed, and how did they do? Started the minimal invasive or percutaneous and all. Then I went to with the 3-4 question, I went to Japan and I find out. Then I have practice on that. Then I convert into endoscopic spine surgery. Then I had a question: how the difference of Destandu versus how they are doing that one. Then I started my journey to find those answer. 1 month with that question, 1 month observership is very good enough, and then you start that practice. So I believe in those things.
Purva?
Yeah, 1 or 2 months would be more than enough in India. That's what I believe. No need of 1 or 2 year of fellowship. That is my thought. But sir, your Manas sir.
Yes.
So before we move ahead, I just want to give you a final message of our young neurospinal colleagues who starting his career, because this is a $1 million question: how to build their career in the academic versus corporate versus freelancing practice, how to choose and grow. Final keywords, because very, very important for first 5 years who choose their neurosurgery career.
See, there is nothing that one can, there is a flat, textbook description how one has to build your career. It all depends on a person's interest, his environment, and his how he looks at his life. I was attending the Young Neurosurgery Forum meeting at Hyderabad. Now, the one surgeon comes and tells that I have lots of financial commitment, so I cannot join academics, and so I have to join practice to earn money. And then another person said that if you have money, you can join academics. Otherwise, you should not join academics. So it is means it's. And then the third person tells that if you have money, you start a hospital and practice.
Yeah, right.
So if you have money, you join practice. If you have money, you join academics. So people are confused because one cannot equate money and earning and learning. So both are different. Means learning, earning can come along with learning also. And many times you have to learn at the cost of earning. So, the primary aim is one has to be fixed whether you want to earn or learn. Okay, and the next is a byproduct. If I feel that I have not learned enough in my residency, then I have to learn by joining an academics. But if and earning comes by as a byproduct. After academics, you can always join practice. But if I have felt that during my residency and during my fellowship, I have learned enough that I'll not do harm to my patient, one can go and join practice and earn as well as learn also. It's not that one earns it's a stop of learning. So that is what every time people think that if he's earning, he's not learning. That is not correct. As Dr. Abhay said, in spite of he came and joined a private hospital, but he still kept on updating his knowledge by attending cadaveric workshops, and attending live surgeries. So earning and learning go together. One will not dissociate, but one has to first decide that have you learned enough to earn. That is the message.
Can I make a statement here?
Yes.
Yeah, this is a very interesting thing because we do not know where we start getting our bread first, or the academics the next. Many years ago, I'm talking about my experience. What I did I joined in a trust hospital, right? medical was a trust hospital, not very big money, small salary, 8,000 rupees of salary. But then you do a lot of cases. You have to understand here very much. You do a lot of surgeries, but you are paid only 8,000 rupees of salary at that time, 1991. It's a moderate for your living. It's okay for you. You can live. When my colleagues were buying cars and others, and in 1 year time, I was just walking on the street but doing a lot of cases. Now the question came that whether to start earn money by doing corporate practice or to go for academic. Now, personally, I feel that you can do academic work while you are in a moderate setup, in a private sector also. There are so many examples. When we published about six articles, six papers in Neurological Society of India, way back in 1994, Professor Matthew Chandy made one statement. Here is one institution coming. This is a private institution called Medical Trust Hospital. But these boys have put 6 papers. Where are they coming? Are they equal to CMC Vellore? Are they equal to Sri Chitra? Are they equal to NIMHANS? AIMS? No. But 6 papers. You believe me, that's the first time Professor Matthew Chandy told me, who's this boy, JKBC Parthiban? I want to see him because we produce papers of 4 papers in spine, 2 papers in aneurysm. Now, academy goes along with your earning. One should not differentiate from academy and earning. You earn, but at the same time, you be logically produce papers, you learn from that. That is most important because everyone will not have the opportunity to join in the best of the academic institution in the country. If I wanted to join in AIMS, I cannot. If I joined the CMC Vellore, I cannot. But I can still join. Like you can see that. Like Manas was, earlier he was in Nizam. I still remember that when we went there for the spine workshop, it is in 94. Manas?
Yeah, 96, yeah.
96, we went there for spinal stabilization technique, development, and Nizam has gone. But Nizam is an academic institution. You may not get much of salary. But at the same time now, Manas is not in academic institution, but he is in corporate institution, but he is doing very good in academy. So it is a mix. It is a mix. The youngsters must be taught in such a way that they need not get worried. Even in the best of the corporate status and best of the corporate places, and in trust setups, you can do a lot of academic work. So it has to go by mix. That is what my personal feeling. So we have to develop, because this is a new generation India coming up. Like Abhay has come from UK. He's totally now he is in Kokilabin. That does not mean that he is sitting there, but now today he is coming and giving a talk. This is academic. Am I correct, Abhay?
Yes, sir. Definitely.
So this is now when you produce more papers, publications, it is beautifully academic. Now you tell me, all of us, let us come to our own friend, Suresh Dugani. What is he doing in a small place? He is sitting in a small, he is not in AIMS, he is not in anywhere. He is sitting in one place, but he is producing so many, he is doing so many good. I'm just taking my friend's name here. So an example for all the youngsters is that not to get worried about where you are going to settle up a startup, but money is essential for life. Money is needed for life. One has to balance accordingly. Need not suffer, but one has to balance in life.
So final concluding remark from all our seniors is, you have a plate in the dinner or the food with which have a learning, earning, and enjoying. So this is a mixed plate you should have, not a single things. And it's already 9:15. So Apurva, should be closing with the suggestion of Parthiban sir and Manas Panigrahi sir with the what do you say, sir? Should we close?
Yeah.
So would like to
just,
thank.
So just if I can ask Manas sir just one last question. Sir, we know many spine surgeons and we are well aware but most of them are they belong to our the fellow branch of orthopedic surgery. As neurosurgeons, do you think we are not able to be strong enough to propagate ourselves only as spine surgeons? There's always a fear of losing on the cranial cases or something, because personally I have reduced quite a lot in my brain work, and I believe to be successful as a spine surgeon, we have to really be into it with all our heart. So do you think there is a lack of zeal or a lack of commitment to spine surgery only as compared to the fellow branch, where they are very confident of advocating and proposing themselves only as spine surgeons as compared to neurosurgeons?
No, I don't think it is the person. Say an orthopedic surgeon has never been exposed to brain surgery, so he is not confused. He has no other choice that he has to choose spine or brain. It is because we are trained in both, we get confused that we don't want to let it go, what we have. And but that was there probably when we were doing residency. But and when spine was not very popular, people didn't want spine surgery at that time earlier. If you tell spine surgery, they would never come for spine surgery. But now people want spine surgery. They want something to be done. They don't want to accept pain. Earlier, we used to make them accept pain. Now people don't want to accept pain. So one can confidently do a full spine practice. It is the person who is interested. He has to make up a mind that he has to let go the brain part, cranial part. Then he can be a better or a more successful spine surgeon than an orthopedic spine surgeon.
Thank you, sir. So would like to give a thanks. Would like to thanks all the chairperson. Special thanks to Dr. Selvan. Dr. Selvan, thank you so much. Dr. Vivek Joseph, Dr. Prakash Moda, to exact time and giving us the special time for us and supporting these events. All the chairperson, particularly Ramani sir, thank you so much. Speakers, Dr. Rakshit, Dr. Savitra, Abhay Kumar sir, thank you so much. Thanks Apurva, Rishabh and technical team Arvind. Thank you so much. We'll meet in the next 2 months with very good topic again. Thank you, sir.
Thank you. Bye-bye. Thank you, everyone. Thank you.
Have a nice day.
Good evening.